morning, everybody. This is Pradeep Pendyala, your buddy, the professor of anesthesiology. Wish you all a wonderful week ahead. Let's talk and chat about a bit about Viva. What happens in an adrenal crisis? Do you know what happens in an adrenal crisis? You should be able to answer it. Very simple. With adrenal insufficiency, the ability to increase cortisol production with stress is lessened, and that can lead to Addisonian crisis. An Addisonian crisis is a life-threatening condition. So you have to be very, very careful. What happens in that life-threatening situation? There will be extremely low blood pressure, low blood levels of sugar, and high blood levels of potassium. Ain't it? Similarly, bronchiectasis is prevalent with COPD, especially in late stages. Most of the COPD cases will end up as bronchiectasis, especially in late stages. Have you heard of left atrial appendage? It's a finger-like extension originating from the left atrium. Atrial fibrillation is the most common clinically important cardiac arrhythmia of all the things, occurring in 0.4 to 1% of general population, increasing with age to more than 8% when you reach an age of 80 years. Talking about muscle relaxant, given the high incidence of recall in emergency trauma cases, even up to 40%, its use is highly recommended when hemodynamics can tolerate it. And you know, thiopental mimics the action of GABA. Everybody, I'm sure, if you are a student of MD anesthesiology, the first thing you learn about thiopentone is thiopental mimics the action of gamma-aminobutyric acid by directly activating chloride ion channels and prolonging its opening. It causes direct myocardial depression, causes peripheral vasodilatation. It also decreases CMRO2, I'm sure you know it, cerebral blood flow and intracranial pressure. And it's useful in the management in the traumatic brain injury. Talking about propofol in traumatic brain injury, it enhances activity of GABAs. It's activated chloride ion channels. Okay, ion channels blocking effects in the cerebral cortex and nicotinic acetylcholine receptors. It also decreases CMRO2, just like thiopentone, cerebral blood flow, and intracranial pressure. It has a dose-dependent respiratory and cardiovascular depression. Less commonly used in trauma, given potential hypotension. It can cause potential hypotension while inducing the patient. Talking about etomidate, how does it work? It augments GABA-gated chloride currents, associated with direct activation of GABA receptors at high doses. It decreases CMRO2, cerebral blood flow, and intracranial pressure. I'm talking about etomidate. It has minimal cardiorespiratory depression associated with adrenal suppression. That's a huge disadvantage, and cortisol synthesis inhibition. Useful for induction of patients with hemodynamic instability. It's not recommended, etomidate is not recommended as prolonged infusion, as adrenal suppression may lead to further hypertension. Shall we talk about ketamine? It's a primary antagonist against NMDA receptors. I'm sure you know that. It binds to non-NMDA, glutamate, nicotinic, muscarinic, monoaminergic, and kappa opioid receptors, ain't it? It produces functional dissociative anesthesia. It causes functional dissociation between the thalamocortical and limbic system. Limbic system. It has minimal respiratory depression. It's a potent bronchodilator. Ketamine. Don't forget that. It causes very strong analgesic. It causes profound analgesia and amnesia. It can potentially increase heart rate as well as blood pressure. Given its favorable hemodynamic and analgesic or amnesic profile, it's the most common induction agent in hemodynamically unstable patients. When you are dealing with hemodynamic unstable patients, don't forget ketamine. Talking about paralytic agent, administration of induction agents is followed usually by neuromuscular blocking agents that allow intubating conditions. Unless you intubate, how would you operate? The neuromuscular agent of choice in trauma is, interestingly, succinylcholine, and the dose is 1 to 2 milligram per kg. It has a quick onset, less than a minute, just 30 to 45 seconds it starts acting, and it's a short duration. It works only for a very short duration, around 3 to 5 minutes, sometimes even 5 to 10 minutes. Whenever difficult intubation case is there, think about succinylcholine. The use of succinyl is definitely contraindicated in certain conditions. I am sure you know it. In which case, neuromuscular agent of choice becomes rocuronium. In such cases, when succinylcholine or scoline is contraindication, go for rocuronium. Okay. And rocuronium doses, what is the dose? We have to give during rapid sequence induction 1.2 milligram per kg. Rocuronium has a longer duration of action but does have a very specific antidote. What is that? Sugammadex. SUGA, double MADA. If rocuronium is used in the setting of non-assuring airway, Sugammadex must be available. Without the availability of Sugammadex, don't use rocuronium when the airway cannot be restored. If you can't control the airway, don't ever attempt rocuronium. It's a long acting and you'll get stuck unless you have readily available Sugammadex next to you. Okay, so that's that. And the worst scenario, when you can't intubate, you should be able to do emergency cricothyrotomy. Thanks for patient listening. Have a wonderful day. Bye-bye.